Hello everyone, I'm Dr. Nancy Gupta. I'm the Director of Crohn's and Colitis Division at Loma Linda University Health. In this presentation, I'll walk you through the origin of black box warnings associated with Janus-Kinase inhibitors. At this time, we have two JAK inhibitors, tofacitinib, which was approved in 2018, and upadacitinib, recently approved in March of 2022 for treatment of moderate to severe active ulcerative colitis. However, there are black box warnings associated with JAK inhibitors, which is why we cannot prescribe them as first-line therapy options. It can only be given to patients who have been previously exposed to anti-TNFs. To take a deeper dive and understand the origin of these black box warnings, we'll have to take a look at the timeline of tofacitinib's approval over the past decade. So tofacitinib was first approved in 2012 for rheumatoid arthritis. Couple of years after, in 2014, FDA commissioned a safety trial by the manufacturing company of tofacitinib to assess its safety in patients who have cardiovascular risk factors. So this trial, which was phase 4 safety trial, came to be known as the oral surveillance study, included patients who were older than 50, had rheumatoid arthritis, and one pre-established cardiovascular risk factors. These patients, they were randomized into 3 groups to receive tofacitinib 5 milligrams twice a day, tofacitinib 10 milligrams twice a day, and anti-TNFs. While follow-up was going on in the safety trial, tofacitinib got its approval for psoriatic arthritis in 2017. In 2018, it was approved for ulcerative colitis as well. However, midway through this safety trial, warnings came along. Patients who were receiving tofacitinib 10 milligrams twice a day, they were found to have thrombosis and death. Hence, these warnings were extended over to tofacitinib, and the indication labeling changed from first-line therapy to second-line therapy. Up until this time, before these warnings, tofacitinib could still be prescribed as first-line therapy, but not anymore. So the safety trial continued. However, there was another change. Patients from the 10 milligram twice daily group, they were moved over to tofacitinib 5 milligrams twice a day and follow up in 2 groups, tofacitinib 5 milligrams twice a day and anti-TNFs continued. It was in 2021 that final results of the study came along. It was noted that higher proportion of patients in the tofacitinib, they had major adverse cardiovascular events and cancers, which is why all the black box warnings came along. And these warnings were not just limited to tofacitinib, they were extended over to other JAK inhibitors as well. Now let's take a look at these black box warnings individually and highlight the key differences between the rheumatoid arthritis population and ulcerative colitis population. Taking a look at thrombosis. So at baseline, patients with ulcerative colitis have 3 times higher risk of having venous thromboembolism. In the ulcerative colitis trial, it was noted that all the patients who developed venous thromboembolism, they had risk factors. Hence, it is recommended to avoid use of JAK inhibitors in patients who have these predisposing risk factors like lupus, protein C, protein S deficiency. Patients are recommended to avoid taking estrogen-containing contraceptives in combination with JAK inhibitors. Patients taking long-haul flights are recommended to take frequent walk breaks to decrease and prevent the risk of thrombosis. In regards to the cardiovascular outcomes, the risk of major adverse cardiovascular events was higher in the oral surveillance study because patients, they had risk factors. Patients were older than 50 years of age. They had rheumatoid arthritis, which also inherently predisposes patients to major adverse cardiovascular events. And patients already had at least one pre-established cardiovascular risk. However, on the other hand, patients in ulcerative colitis trial, they had lower incident rate of major adverse cardiovascular events compared to that which was noted in the oral surveillance study. Now, Patients with ulcerative colitis are also relatively younger and have lower cardiovascular risk factors. Nevertheless, extreme caution should be exercised when prescribing these medications to older patients or patients who have long-term cardiovascular risk factors, because we do not have long-term evidence of the effect of JAK inhibitors on the long-term cardiovascular outcomes in ulcerative colitis population. In regards to the risk for cancer, patients in the safety trial of rheumatoid arthritis, they had advanced age, and advanced age by itself is a risk factor for cancers. However, in the ulcerative colitis trial, the incident rate for overall cancers was much lower. However, the risk of lymphoma and non-melanoma skin cancers was still high. So when we are prescribing JAK inhibitors to our patients for ulcerative colitis, we need to counsel them regarding these risks, slightly higher risk of lymphoma and non-melanoma skin cancers, and offer them and recommend yearly dermatological surveillance besides the age-appropriate cancer screening. In conclusion, I would say, when prescribing these medications, risks of the therapy must be weighed against the benefits. Instead of approaching these medications with trepidation and alarm, we should be fully confident about these medications so that patients who can truly benefit from these therapies could avail the benefit. Thank you.